We'll just wait a few minutes for everyone to join. Still joining, so let's just wait a couple more minutes.
Sophia, just a quick question as we wait. Do you expect us to launch and manage our own presentations, or will somebody be able to support us? Thanks.
It's up to you if you should have access, but would you like me to do that for you?
If you could be on standby, just in case for some reason I don't do the screen share, that would be fantastic. Thanks so much. Thank you.
Thank you. Right, I think we can start now. So welcome everyone to our EPI-WIN webinar on the monkeypox outbreak. How is monkeypox spreading? What we know so far. It's a very topical issue right now. As you know, the monkeypox outbreak has been declared a public health emergency of international concern. But monkeypox, as I'm sure you know, has been around. It's been endemic in West and Central Africa. But what's different now is that it's spread to many non-endemic countries, to more than 60 non-endemic countries across all 6 WHO regions. The question that's been on everyone's mind is how is it spreading, and what can we do about it? As the science evolves, we're learning more and more about this particular outbreak. But today, to tell us what we know so far, we have 4 eminent experts. We have Dr. Boris Pavlin, who's the epidemiology lead for the monkeypox response in WHO. He will provide a global picture of how monkeypox is spreading and what we know so far. Then from the WHO Regional Office for Africa, we have 2 eminent epidemiologists. We have Thieble Traoré and we have Jean-Paul Kimenge, who will essentially give you the picture there and tell us how we got from the first monkeypox cases to a public health emergency of international concern. But that is how the spread is happening. But ultimately, it's us, the people, the communities that can make a difference. And we have Andy Seal, who's a technical officer in the WHO Department of HIV, hepatitis, and sexually transmitted diseases. Am I correct there, Andy, in getting all of them right? Who's been working extensively with vulnerable populations. And he will give us insights into what we can do. and to help in this situation. So without further ado, I hand over to Boris, and after Boris, we'll hear from Jean-Paul and Thierry, and then finally from Andy. Over to you, Boris.
Great, thanks. It's my pleasure.
Sorry.
Yes.
Sorry to interrupt you. Just before you start, though, a few housekeeping rules. Sorry about that. This session is being recorded and also broadcast live on YouTube. And if you please also put all your questions in the Q&A box, not on the chat, but on the Q&A box, so that we can see it immediately, and all our experts will respond to the best of their ability as the webinar continues. So over to you now, Boris.
Great, thanks. Can I confirm that you can see my full screen?
Yes, we can see it.
Great, thanks. Okay, so first, to just give you a general epidemiological update of where we are with the cases. The increase in cases globally really started in late April, early May. But if we go back further, we realized that there were, in fact, simmering cases that were rising in the African countries that had previously reported cases. And my colleagues will talk more about that. So we've created this curve that looks at what's happened this year. And you can see that since May, the number of cases globally has gone up dramatically and continues to rise dramatically. Since January, we've had 75 countries report cases in all 6 WHO regions. And as of the 22nd of July, the full week, we had just over 16,000 cases, laboratory confirmed, and a few probables, as well as 5 deaths, all of which have been reported from the African region. This is very small, but I would just wanted to show you that the number of, sorry, the numbers there from the last time, but the greatest number of cases globally has been from the European region in general, and specifically from Spain, followed by Germany, the United Kingdom, France, and the Netherlands. And then in the region of the Americas, actually the United States of America, Canada, and Brazil with a huge number of cases. There are a small number of cases in the other regions, but those are the 2 dominant ones. And you can see here on the map, represented visually, where the highest number of cases are in the blue colors. Now, we do have to keep in mind that that monkeypox is a disease that not everyone has had diagnostic capacity for. And so, for example, in some of the countries that are not reporting cases, there may be limitations to the diagnosis because it requires a laboratory confirmation. If we look at the individual countries with the most reported cases, and the numbers, the countries themselves, the words are very small, but the point here is that a few countries have seemingly brought their outbreaks under control, where other countries continue to have a meteoric rise in the number of cases. The differences in why some of these curves are different from others is still being looked at, in terms of particularly, for example, the response strategies and to whom vaccination and other measures are being able to be applied. But one thing that is interesting to look at is the difference between individual countries, where some of them seem to have plateaued, and the overall epidemic curve that I showed earlier, which clearly shows that the outbreak continues to rise very quickly. And this can be attributed to the fact that even though in countries that early on had experience and who early on had the outbreak and have in some cases brought the cases down, the outbreak continues to spread to new countries. And so globally, new countries are being added every day that increase the overall number of cases reported on a daily basis. And it is concerning that some of these countries that are now only for the first time reporting cases, one of the reasons they may have done so is because of a lower capacity to detect them in the first place. And so we may not see as high a level of reporting of each case that might be out there. In other words, the ascertainment ability of all the cases as we move into countries with less capacity. So we may see a lowering of the curve, even if in fact the countries, the number of cases continue to expand because we've moved into countries with less ability to report. Overall, the case demographics are as follows. These are from last week, but they haven't changed. We are able to get almost the vast majority of reported cases. We actually have case details for, which is fantastic. And you'll see that basically 99% of them are in men. And of those for whom their sexual orientation is known, 98% of those are men who have sex with men. There are a small number of females. There are a small number of people who don't characterize themselves as men who have sex with men, and there are a small number of children reported. But for the most part, this has been stable over time, that the outbreak has been almost exclusively in men who have sex with men. And in fact, when we look more specifically, it's not, of course, any man who has sex with men, but men who have had multiple sexual partners in the past few weeks, including in settings where the exposure is to multiple partners simultaneously, sometimes anonymously, parties, bars, and other large gatherings, which makes it difficult to understand exactly who where somebody has acquired their infection. We also know that there have been a fair number of health workers infected, but as of now, for the most part, first of all, it's difficult to know. Not all of these are reported accurately. So there may be more health workers, but what's more relevant is that most of these health workers, being also members of the community, reported community exposure rather than through healthcare transmission. As of now, we don't see healthcare transmission from infected patients as a major source of infection. The symptoms in this outbreak, in some cases, have been quite consistent with what we've seen in the past, which is a set of non-specific things like fever and headache and so on, followed by a rash that characteristically spreads throughout the body and has the individual pustules or papules, the rash elements in the same stages of development throughout the body. On the other hand, we've also seen some features here that have not been sort of the classic presentation, such as people who first develop a rash, then develop additional symptoms, people who only develop a single rash, a single vesicle or pustule, the lesions, or people who don't even who can't even say for sure that they've had a rash, and also some of them being within the mouth and other mucosal surfaces, such as inside the anus, which makes it difficult to find them and know that you have them in some cases. Some of them are quite painful, but some people have also reported not having any symptoms or signs that could be identified by a medical official. Many of the rashes have been genital or perianal, so and this is consistent with the way that they were acquired. The bottom line is that for the transmission, the main source of transmission is skin-to-skin contact, And much of that has been happening in the context of sex because you get a lot of skin-to-skin contact, but it is also the mechanism that other people, for example, household contacts of cases, have gotten it. As of now, we haven't seen more than one or two possible examples of respiratory transmission, although that is a known mechanism, but it is not, overall, this virus is not as transmissible as, for example, COVID, SARS-CoV-2, and it is definitely not as transmitted as easily by the respiratory route. We've also seen some new features of symptoms and signs that had not been previously reported, such as proctitis or inflammation of the prostate gland. Some cases have been hospitalized. Some of these for clinical care, others simply for isolation. A few cases hospitalized in intensive care, including for severe pain management, because the rash can be quite painful, but none outside of those 5 cases that I mentioned that are in Africa, none of the cases outside in the newly affected countries has been fatal. WHO has assessed this, conducted rapid risk assessment and has had 3 versions of it, and they at all times remained as moderate global risk, with a higher risk in the region of Euro, and also a low moderate risk in the Western Pacific region. The main reasons we've assessed it as such is that it was found widely in many countries at the same time. It is traveling through sexual networks, which makes it very quick to travel. The fact that some cases have been identified, many cases in fact, that could not explain their exposure, indicates that this virus has probably been circulating for a few months before we became aware of it. And there's some genetic evidence that that some of the mutations have made it easier to transmit amongst humans than in the past. Originally, and I'll talk about this more, this has been considered a zoonotic disease, or a disease transmitted from animals to humans. But in this outbreak, this is not what's happening. We're seeing entirely human-to-human transmission. We have not seen, while it may have started from an animal, it certainly would have at the very beginning. We are not seeing ongoing transmission from animal reservoirs in any of these countries. And we have not seen any infections back into animal reservoirs either, although it's something that we're worried about could happen. People in general are not immune to monkeypox around the world unless they happen to have had a vaccine for smallpox because they're older, or for whatever other reason, which is the vaccine is highly effective. It has an efficacy of around 85%. But again, it's not something that most people were vaccinated for. The smallpox vaccine has been discontinued in most of the world. So people are not immune in the way that they once were. And we're worried that monkeypox may actually take over the ecological space, the niche that smallpox left behind when we eradicated it. When there was smallpox around, monkeypox couldn't take a foothold because there was more widespread smallpox disease and vaccination that covered both. There is a possible risk of asymptomatic or pre-symptomatic transmission. We've seen that a few cases were asymptomatic and had PCR evidence that they were infected, but not live virus nor evidence of, actually, I might be wrong about that live virus one, but no evidence of ongoing transmission from an asymptomatic person yet. Doesn't mean it's not possible, but it's something we're looking at very closely. Most countries don't have experience with the surveillance of monkeypox or the treatment clinically, and so this is a concern. And we don't have sufficient laboratory capacity or medical treatments or vaccines to provide to everyone that would ideally potentially be eligible or could benefit from these. On the contrary, the reason this is not a higher risk is because it is presently at very low mortality, and because it is limited to certain demographic groups and has not spread beyond those. So there is a still possibility of containing this and stopping the transmission of this virus by working through the affected communities and good public health practices. I'll just talk a little bit more about some of the considerations that the emergency committee recently used in its evaluation of whether this is a public health emergency of international concern, which in the end, it was decided, it was declared so. I'll skip over that for now. One of the considerations was whether it was increasing, whether it was continuing to spread since the last time they met. Of course, the number of cases has increased, but the rate of growth has not substantially increased, and it has not particularly gone out beyond the population groups currently affected. The proportion of cases outside of men who have sex with men has remained low. It has clearly spread to additional countries in the countries that have previous no experience, but it has also spread within countries in Africa that my colleagues will talk about more, and possibly because of actually not only the ongoing risk that the wild animal reservoir presents in Africa, but because of human-to-human transmission. We have more cases than we've had in the past in Cameroon, Central African Republic, Congo, the Democratic Republic of the Congo, and Nigeria. The committee was also concerned about the possibility that it would spread to other groups that are at high risk for transmission of diseases, particularly through skin-to-skin contact, in particular sex workers. We have not seen this as of now. There is anecdotal evidence of a few individuals who have continued to, for example, conduct sex work despite being infected. And we also are concerned that there are places where perhaps the surveillance has been too focused on men who have sex with men and may potentially miss cases in other members of the community. But it's something that we need to keep a close eye on. As of now, it does not appear to have spread outside in any major way. And then the question of whether it's spreading to vulnerable groups, such as those with immunosuppression, pregnant women or children. Again, very small numbers in outside the major demographic. We have had now maybe 2 pregnant women, a handful of children under 10. These have been primarily through household contact. We haven't seen any reports of school children spreading to one another. And so in general, as this is something that is spread primarily through skin-to-skin contact, and because it does in many cases make you quite ill, we're not seeing a lot of ongoing spread, even if it gets from one household member to another. You know, it's not then getting from that child to their schoolmates, for example, in any major numbers. In Africa, we see a very different demographic, and my colleagues will talk about that. It's much more mixed, gender-wise and age-wise, and I think this reflects a different epidemiology than what we're seeing in places like Europe and in the Americas. In terms of the actual increased severity, we haven't really seen that. Again, there are some cases that are severe, but expected given the large number of cases. I mentioned that we've not had any reverse spillover into animals to establish a reservoir. In 2003, I believe it was, in the United States, we did have the outbreak of monkeypox linked to pet rodents. And all of those and then people were infected from their pets. We are concerned that it could spill back into pet rodents and so on. So we do advise that people with monkeypox refrain from remove their pets from contact while they're infectious. In terms of the actual genome, the virus changes. Whether anything has changed dramatically, this is still under investigation. And in terms of the last criterion they were looking at, which is whether there are a few different clades or types of the virus, and one that has historically been called the West African clade, or clade 2, is the one that has been associated with this outbreak. And the other one, the Congo Basin or clade 1, is thought to be cause more severe disease, but this has not been identified in the current outbreak, although there is limited capacity to detect it. With that, I will just say there has been some estimates at how this transmission is looking overall and whether we're at the whether things are improving or not. And we have a few models that have been done by the European Center for Disease Prevention and Control. And there's a thin blue line there in the middle. Don't look at the overall light blue that looks like it's going up. That's the limits of the estimate. But the main estimate, the central estimate, is the thin blue line. And you can see that it does show some plateauing, although it's also very hard to be certain. And that's what the wide blue confidence interval shows there. I'll skip that one and that one. In terms of other transmission issues in the clinical setting and in terms of infection prevention and control, we have seen live virus identifiable all over patients' rooms. At the same time, the staff treating those patients has not gotten infected, so the infection prevention and control measures work as expected. We also have a small number of air sampling test samples that have been positive for the DNA of the virus, not for live virus, which indicate fragments of the virus circulating in the air in those rooms, which again is to be expected. And given the fact that these patients were undergoing what we call aerosol generating procedures, this is not unexpected. We haven't seen any transmission, as I said, based on these issues. It's further studies are needed to evaluate whether this will be a significant method of transmission or not. My personal view is that this is vastly more about the skin-to-skin contact. Again, different clinical features, and in some cases milder clinical features than historically reported, which could lead to transmission by people who are not aware that they're infected, which is why we ask contacts of cases to be very vigilant about any possible symptoms and to report them as soon as possible. Again, I've mentioned subclinical or asymptomatic infection, but we have not seen any asymptomatic transmission. We do, from our limited understanding of the timing of transmission, we do believe that the prodrome, or the period where people starting to show symptoms but not yet have a rash, is already infectious. But otherwise we are not. So in that sense, you may not know that it's monkeypox, but still be able to transmit the disease. And so again, this is where contacts in particular, but also anyone who engages in high-risk behaviors that might be associated with catching monkeypox, should be aware of their symptoms and report to public health authorities as soon as possible. I just want to point out that there are many that the gatherings, in particular around Pride events, have taken place and are ongoing. And we do need to be. This is one of the reasons why that curve that shows a leveling off projected has some uncertainty with it, because at any time we could have some events where people where additional cases where more additional cases occur. And then finally, just to bring it back to the animal-human interface, while we're not currently seeing animals as a major source of infection, in this outbreak, we will never be able to fully put the genie back in the bottle unless we can address this transmission of animal to human, and particularly with people interacting with wildlife, hunting bushmeat, and eating bushmeat and so on. Cooking food will disable the virus, but the processing of it, the hunter is at risk, could then spread it to their family and so on. And as of now, we don't actually know what that animal reservoir is, which makes it much more harder to control, because we can't even message people about exactly what animals they should be avoiding. It has been found in many animals. Just making sure I've covered all the questions that were asked ahead of time. Animal symptoms are similar, in fact, to humans. They have tiredness, fever, rash, lymphadenopathy or swelling of lymph nodes, many of the same things that we have. Is there any risk for pandemic spread? I think I've described how this is spread, and it's certainly all over the world, but in specific demographics. So it's hard to say what happens next, but as of now, we're not seeing major spillover into the general population, I would say. Vaccination has been advised for high-risk persons. Where possible, pre-exposure vaccination is being administered, for example, to healthcare workers, or in some countries with sufficient capacity, even to people who engage in high-risk activities outside of healthcare, but certainly for post-exposure, to limit the chances that you develop disease, and especially if you have a risk of severe disease, to prevent that most serious thing happening. In terms of international precautions, I mean, transboundary spread has already occurred. We are not advising travel and trade restrictions, and it's virtually impossible to screen for all cases of monkeypox at international borders. It's really about appropriate community messaging and screening. Every country should be, if they haven't detected cases already, should be heightening their surveillance for potential cases. I think I've discussed why it's spreading among men who have sex with men. It's skin to skin contact, and people who have multiple sexual partners increases your chances, and sex is a very close skin to skin experience. There has been DNA found, monkeypox DNA found in semen, and I believe even live virus, I believe. But again, the extent to which this is important is, as of now, not known, and given that sex usually involves skin to skin contact in the first place, that's really the more likely way, I would say, that it's going to continue to spread, and what we need to be most worried about. I've talked about these other things. Will the monkeypox, okay, I think I've covered all the rest. So with that, I think I'll stop there and hand it over to my colleagues. Thanks.
Thanks very much, Boris, for that very comprehensive global overview, and for answering so many of the questions that have been sort of troubling some people who wrote in to us. With that global overview, now we go on to our colleagues in the Regional Office for Africa. Jean-Paul will give us an overview of what's happening in Africa, followed by Thieble, who will lead us from, from the 1970s to how we come up to the public health emergency of international concern. So over to you, Jean-Paul.
Can you please share my screen?
Right.
My presentation, sorry.
This is the one, right?
Yes.
Yes. Okay. Can everyone see it? Great.
Okay, thanks very much. I will give an overview of the situation on the African continent. I think Boris have already given the global situation of monkeypox. So please move to the next slide. There are some slides that I will not present since already have been presented. Go to the next, please. Then the next. So as far as the African continent is considered, we have now 9 countries reporting cases of monkeypox. So the majority of those countries are countries where monkeypox was reported previously in previous years. So those countries include, for example, Cameroon, Central Africa, Republic of Congo, DRC, Nigeria. However, we have other 2 countries where monkeypox was not reported previously. These are countries such as South Africa and Ghana. So you can see on the map that the majority of cases are being reported from DRC, Nigeria, and now we are seeing an increasing number of reported cases in Ghana. Go to the next, please. So from this EPI curve, you can see that we started observing an increased number of cases starting from mid-April. And till that time, till now, we continue to see countries reporting cases. But mainly this increase is driven by DRC, Nigeria, and as mentioned, in Ghana. So some reason can explain, some fact can explain that increase. Partially, we can talk about the surveillance capacity which have been strengthened, and also there is laboratory capacity that have been strengthened in those countries. This may explain partially the increase in number of cases we are registering. Next. So if we try to look into the demographic of the population affected, you can see that 60% of the affected populations is male. Then majority of the affected person are under the age of 39. The median age being 20 years old, isn't a quarter range between 9 and 32. So you see that the young age is more affected. Next, please. So with data available, if you try to look into the clinical presentation of patients, you find that the majority are presenting with fever. Then we have lymphadenopathy, pains and dysphagia. We also have some cases with rash and headache. So this, we need to look into this with the cautions, because some data collection in our context is not really done systematically. There are some limitations in data we receive from the field. Next. So concerning the laboratory capacity and sequencing, yes, on our African continent, also we are able to do some testing. And the many tests being done is the real-time PCR, monkeypox prime, or CRIDE-specific prime. So these are other details about a specimen that need to be conducted, and available detection kit. So this is just to show that the capacity is there at our continent. Go to the next, please. So concerning sequencing as well, some sequencing are being done. And from the database, for sequencing database, we have data from 8 countries in our continent, which are in the public database. So for example, if we look into Nigeria, we know that in the database, they have sequenced a total of 90 samples. And all of them, they were identified as clade 2. Also, in South Africa, we know that a sequence for 3 samples was done. So this is what is in the database, but we know also some countries have done sequencing, though it's not registered in the database. So all the 32 COVID sequencing lab on our continent, they have capacity to sequence any pathogen. So we do encourage lab to deposit monkeypox sequence data on public platforms such as this GSAID or GenBank. Next, please. So I want to give just a picture in some countries to see what is the situation and what have been done in terms of investigation. Go to the next, please. So as I have highlighted previously, we continue to observe these increasing trends of cases in Nigeria, DRC, and Ghana. As you can see on this EPI curve shown on the top right, you can see that Democratic Republic of Congo and Nigeria, they are one driving this increase. As well, we have highlighted Ghana since in the last 3 to 4 weeks, we have seen an increase from 5 to 34 confirmed cases. Next, please. So let's take an overview of the situation in the Republic of Congo. So from the available information, we know that monkeypox was reported in the Congo in the last 5 years. So for the last 5 years, we know that a total of 132 cases, including 9 confirmed and 7 deaths, were reported. Then the majority of those cases, around 80%, were reported in Lukwala province. Also, we know that Kivet and the Plateau province reported cases in 2019. So concerning the situation in 2022, this Republic of Congo have reported 8 suspected cases. Among them, there are 2 confirmed cases, and 75% were female. And we know that 4 among the reported cases were from the same family. And according to the investigation, those affected, it started in one family where people consumed meat of a local animal, which is called katuku or poto. So this animal was having an abdominal wound. Then we think the transmission started from there, according to the finding of the investigation. Go next slide, please. So this is a map on our left, trying to show you where is situated the department affected. You can see Likwara, you can see the proximity as well to the Central Africa. So, and on your right, you see a picture of the investigation team just trying to talk with the population to understand well the dynamic of this outbreak. So you can see that this is a remote area in the forest where they reported those cases. Next slide, please. So let's also have a look into the situation of Central Africa. From the historical data, we know that 40 monkeypox outbreak was reported starting from 2001 to 2021. So we know that also these outbreaks were reported during the rainy season or during the beginning of the warm season. This is between June and December. So these around 40% will just outbreak that will transmitted through contact with animals. So I have mentioned as well that correlation with the seasonability, which was established. So as you can see, starting from 2001, on this EPI curve, you can see that almost every year, there are some cases of monkeypox that have been reported. And we see a big number in 2018. Then 2020, the number of reported decreased. Maybe this may be explained by COVID. So the priority of surveillance was given to COVID. This may explain partially the reason why we don't see the same number of reported cases. So on the map in 2022, now we know that 3 districts are reporting cases. These are Bimbo, Mbaiki, and Alindawo. We have 3 confirmed cases and 2 probable. So this map is just to illustrate those areas that have been affected previously, starting from 2021 and 2022. So most of the areas are in the forest and remote area. Next, please. So some studies also have been done to analyze data in Central Africa. As you can see, this analysis that was done on available data, where you can see that concerning gender, if you analyze data, we find the predominance of female. Then we have also the age, which is around 15 years, the median age. And the age group affected also, you see that the majority are the age group under 29 years old. So the finding of this is in line also with other findings for studies. For example, in DRC, they found that the mean age of affected population was 11.9. And in Nigeria, it was around 29%. Next, please. So this is part of studies that have been done at the country level. I think it was in the collaboration is AfriPox project, where they try to analyze the transmission cycle of this virus in Central Africa. You can see that, like I highlighted, there is a huge percentage of people that are infected starting from animal. Then we have also some cases of secondary transmission where when this gets to human, it can go to other humans. This is what we are trying to illustrate on this figure. Next, please. So for Nigeria, so we mainly want to show that during this year, this outbreak was special compared to other years. We know that this monkeypox is one of the emerging diseases in Nigeria. The first case was reported in 1970. Then we have seen starting from May 2002. This is what you see on the black line, which is showing that starting from May, we have seen an uptick of monkeypox cases. So this shows that we have already gone beyond the peak of cases seen in 2017. when monkeypox re-emerged. So as explained previously, the reinforced surveillance, the reinforced laboratory capacity, and the reinforcement of risk communication may explain partially why we are seeing this uptick in number of cases. Also,
sorry, Jean-Paul, sorry to interrupt. Could you please start wrapping up because we don't have a
yes, yes.
Okay. Sorry to interrupt.
So the West Africa strain is the one that have been detected for this outbreak in Nigeria. Next, please. So the age group is the age group, younger age group, under 40 years is the mainly affected. Move to the next. Move to the next, please. And this is the map showing where we are reporting cases in Nigeria. So in conclusion, 9 countries in Africa are reporting monkeypox outbreak. And among them, 90% of them have been reporting cases previously. So Ghana and South Africa need more attention, so because they were among the countries that did not report cases previously. Then we have highlighted the support that is being given by WHO Afro to support countries to reinforce lab capacity and sequencing. Thanks very much for your attention.
Thank you so much, Jean-Paul. Now I hand over to Tieble, please, to tell us a little more. Once again, Tieble, in the interest of time, could you please keep it as brief as possible? Thank you.
Okay, thank you very much, Supriya. I will do my best to be short. Can you hear me?
Yes, we can. Thank you.
Okay, do you want me to present from my side? Okay. Okay, thank you very much and welcome to the EPI webinar. And for monkeypox, the first case was detected in Democratic Republic of Congo, and especially in the Basankusu territory. And that was in 1970. And it took almost 52 years for the disease to be declared public health emergency of international concern. So, and as you can see, the virus, I think, claims due respect now. And so for most of you, you would wonder, you will ask the question, where was the virus at that time? Or where were we at that time? That's the responsibility of everyone, not only WHO. All agencies involved in public health and all individuals on this planet concerned about health, that's our responsibility. And okay, I will move on a little bit from small territory to the global. If you look carefully, Basankusu was in a Equateur district, and you can see how the first case was detected. That was notified clinical on 22nd of August 1970, and it took few days until September 1st to be presented at the hospital. So at that time, if the interaction between the first case and the rest of the family member and even in the community was very, was kind of dynamic, and the case contact had several contacts, the infection would spread quickly. But was that the case or not? You will find out with the history data. If you look carefully again, between 1970 and 1979, you can see in DRC 38 cases, and the rest of Africa, these are the number of cases. I think you have seen this slide from Boris and from Jean-Paul, but in 1980, that means from 1980 to 1989, you had more cases again. That means wherever you see increased number of cases, there is a transmission. And it didn't stop there. Again, 1990 to 1999 and 2000 and 2009, you can see how the number of cases were increasing. So transmission was going on. And even from the endemic region to the USA, you have seen why these cases happened when that was from the animal traveling from Africa to the US. And so travel was one of the factors. And that means the globe, we are very close to each other. We are one world, and you will see the importance of this again. Let's look between 2010, 2019, and you will see how DRC, the number of cases, even though you have a lot of suspected cases here, but Nigeria as well, 181, confirmed and probable. These are really well-defined cases, and you can see where UK is at that time. So these were just kind of alert. I'm not saying the world was sleeping, but it is up to you to make that conclusion about, we were electing, or we were neglecting the disease. It's up to you to make that conclusion, not me. And so increasing number, transmission, and the transmission potential, we have seen virus can two pertinent questions, these questions were addressed in 1988 by Fine a colleague. That's where particularly I learned from it. And the question given was the epidemic potential of monkeypox in vaccinated human population. I think today we can see most of us were not vaccinated against smallpox, the young generation. And we have seen that now there is a potential for epidemic, and there is no question about it. It is declared as a public health emergency of international concern. So it took a few decades for us to know that. Is it possible that monkeypox could persist in vaccinated human population? Now, through person-to-person transmission, you have seen the presentation from my colleague Boris, and I think if we don't do anything, we will find out the answer of that question in the future. So it is up to us to stop this now, and we cannot do it without all of you. And we have shown a good example of smallpox eradication, and that led to the intensified surveillance for monkeypox. And monkeypox was detected because of collaboration of hospital and healthcare worker and community. And you will hear about community by my colleague Andy in the next presentation. And the knowledge of clinical cases is very important. Laboratory as well, collection of specimen, and testing, confirmation are all critical factors. And they are paramount for the detection of monkeypox and to mount rapid response as well. At that time, if you look, specimens were sent in the US and Russia. But today, Jean-Paul showed you the capacity we have in our region. And technical assistance, very important as well for monkeypox detection. And without the community, based surveillance, the implication, it will be very hard because in the history, if you look historical data, in Democratic Republic of Congo, the currency was Zaire at that time, $90 US dollar was given to anyone who could report monkeypox. And that's why that was one of the motivation factor. So you cannot do the surveillance without technical support, without motivation, and all to stop the transmission. And whether that was sustainable or not, and it is a big question. So transmission again. Transmission, if you look, there are two critical elements which we need to consider. That's the secondary attack rate and basic reproduction number. People will ask, why are you talking about this? Because if you don't know this, and without good data, very good data, line-less data, and proper follow-up, you will not be able to know the exact transmission, what's going on. You could have a really severe chain of transmission going on and detect it. So, and the relation of this, we can explore them. I'll give you an example here. In Africa, what was calculated in the past, historical data from DRC, which was good. The secondary attack rate, you have the secondary cases, so you need really to know the epidemiology, the clinical aspect of that to do that. And individually in the contact with first case. In Europe now, it will be we have an estimate, but very hard, because one person can contact 1,000 people. And you don't know all of them. So these are the parameters we need for transmission in Africa. If we want, without good data, we cannot. And colleagues are working with countries today to get line-less data and to get appropriate clinical data as well, to be able to know exactly what's going on in Africa. In the past, these were calculated based on the rash, the serial interval, and that's good data. So we know about the monkeypox. That's a 41 multiple case monkeypox outbreak in DRC, calculating. And you can see from the first one to up to the last. So the contact, if we believe contact is very important, then the number of cases and contact were calculated in the past. You can see the majority had several contacts. But the vaccination is important as well, monkeypox, to stop the transmission of monkeypox. But again, one case can have several contacts, more than one occasion. And so these need to be considered in the transmission. There was a question about the vaccine efficacy. And these were calculated already. And you can see some of the estimates. And the transmission was lower in the vaccinated. That means protection for the vaccine. You can see it on this slide. I will be fast to wrap it up, but that's the kind of protection of smallpox vaccine protect against monkeypox. That means probably another question is monkeypox was around before 1970. That's a speculative question. It was around, probably just not detected. Okay, again, if one wants to know exactly the transmission in Africa, again, there is a good model. It was calculated, and it was concluded that there is a possibility for the persistence of the virus in the population. And it is here at least. That was the conclusion of that. But the rate, the reproductive rate calculated was 1 if the population is not vaccinated. But again, that will depend on the mixing of population. Okay, but there was a concern about if the virus gets into crowded urban city in Western Central Africa, what will happen? The rapid spread. But that was not the case. until 2017 in Nigeria. And we have seen really an increase number of cases. You have seen that, but it was controlled, and because they intensified surveillance and detection. But today we have seen what's going in the West, the Western world, and multiple countries today. The virus introduced in the urban area, and there is no question monkeypox is about transmissibility of monkeypox. 30 years after smallpox.
So sorry, but
Okay.
could you please start
Yeah.
wrapping up, because we've actually run out of time.
Okay, I will go around. Okay.
And Andy
So-
also has his.
Yes, okay. This has been shown to you, and the reason to show this one is the complexity in the transmission dynamic of monkeypox. Why? If we believe it is in an animal population, there is a model for it, but model can be more complex. It's not one parameter to be used, and more study need to be done to conduct this kind of analysis. And at the human population level, you can see how the socio-economic factor can complicate it. So the lesson to take is to strengthen the surveillance based on the attribute of surveillance in the human, animal population, and environment. And this is an ecological study going on in Central African Republic, AfriPOX. The One Health approach is taken, anthropological approach is taken to characterize the risk factor and the transmission dynamic of monkeypox. So based on what's going in the region, we need to strengthen this area, multi-sectoral approach, surveillance, treatment, infection prevention, risk communication, and research. Here, I will thank you for your attention. Okay, over to you.
Thank you very much, Diable, for that historical perspective. Now, as you mentioned, risk communication, communicating with communities is essential. So over to Andrew, and I apologize for the time management. We've run a little bit over time, but if you bear with us, this is really important what Andy is going to tell us. Over to Andy.
Thank you so much, Supriya. Do you see my slides? Let me try again.
Andy, they're not in full screen, otherwise we see them.
Great, thank you so much. Right, let me put that into presentation mode. Okay, so let's go. First of all, thanks to my colleagues who've already presented. I think it's fantastic to have this opportunity to really go through and try and encapsulate what we know now. This is a very dynamic environment. We're learning all the time. And indeed, even the questions that are being posed in the chat are really helping us in thinking through critical steps that we need to prioritize as part of this response. I think this slide has been covered very well by other colleagues. So I think the only thing that I will try and emphasize here, because questions were raised in the chat, are, why is it that MSM in particular, and Boris and others have touched on this. I think the critical thing to note is that men who have sex with men are often connected to quite dynamic sexual networks that extend across different cities and countries. So it's not untypical for men who have sex with men to have perhaps more than 3 partners a month, which is very different to most heterosexual populations' experiences and reports of sexual partners. So you can already get a sense that, that increased density and connection sexually and socially, it means that if a virus is introduced into a community like that, it can quite readily take hold. And I think we've answered questions in the chat about household transmission, onward household transmission, because of course sex and close skin contact during sex is not the only route of transmission. And it's important that we hold on to that. Communities have been informing our work from the beginning at WHO, and the interaction between health authorities and communities really is critical. So I think number one message from my presentation is, we need to identify which communities are most affected. So that will be a fairly diverse group of communities in West and Central Africa, but it'll be a very focused set of communities elsewhere. And even in Western Central Africa, I think it's important that representatives from MSM communities are brought into the conversation as well. This question has come up in the chat. We need to find out more about what's happening in the context of sexual transmission on the African continent, but we can assume from what we've seen elsewhere that this is likely to be contributing, sexual transmission is likely to be a contributing factor, skin-to-skin contact during sexual transmission. We have public health advice that we've developed with communities of gay, bisexual, and other men who have sex with men that really emphasize this point about how the virus is spread. So stick to the facts, avoid speculation. I think with so many multiple possibilities around transmission, it is really important that we describe what we see. So as Boris really eloquently presented, although there is the possibility of transmission through contact with fabrics, potential face-to-face transmission if somebody has infection, has lesions within the mouth. Theoretically, if you're having a very loud conversation with somebody, for sure, the respiratory droplets could be a route of transmission. But for now, we're not seeing that these other modes of transmission are playing a significant role in the outbreak that we're seeing outside of Africa. It is largely connected to close intimate contact that occurs during sex. And we've also heard from colleagues about the possibility of symptoms not being very obvious. So people obviously who are sick will not be looking to have sex, but some people who are haven't recognized or felt very ill or have no visible lesions on their skin may be unaware that they're in fact experiencing a mild version of the disease. So we need to, there is advice that's specifically for MSM communities that I think we should all be aware of, and we should all try and amplify and support affected communities, whether they're MSM or the broader communities in the African context. So the advice is fairly similar for everybody. It's really learn more about how monkeypox is affecting your local community in particular. So again, it's about, finding out as much as you can so you can take calculated decisions about your life. So for example, if you are somebody who regularly changes sex partners, it's possibly a good time to be thinking about that. Is this a good idea to be doing this now? Should I, stay with one or two sex partners that are known to me? This idea that we need to connect as well to our sex partners should we be exposed is also critical. So in the earlier days of the outbreak in Europe, there were some amplifying events where, frankly, there was a level of anonymity within those sexual contacts. Already we're seeing behavior change happening so that men are really reducing their risky sexual behavior, particularly where vaccines are available. So they're trying to get access to the vaccines and adjusting their sex lives accordingly. This may be linked to some of the plateauing that has been observed in some countries that Boris described at the beginning of this conversation. Again, we're learning as we go, that there's a lot of data coming in, and we're making sense of this in real time. I think one of the critical things that we all need to be aware of is that there's a high level of potential for stigma and discrimination here. It's very similar to what we saw through HIV. So again, the fact that we have a disease that seems to be predominantly affecting African people and men who have sex with men has already led to racist and homophobic accusations, communications, particularly online, which seems to be a very unregulated space these days. But we have to remember that we all have a role to play in really addressing this, spotting it where it takes place, and noting that stereotyping, stigmatizing, blaming, or shaming anybody is harmful. UNAIDS has really partnered with us in this effort and will continue to do so. But I think we all have a role to play. And also we have to do this thoughtfully. Calling out for targeted resources for communities that are clearly affected is not homophobic. not allocating resources is not, it could be homophobic. And I know there's a big debate that's been happening online about exactly that. We have to be factual in responding to what we see, but at the same time, we do have to be very sensitive to how we can do this in context, and contexts do change. So we know the context for men who have sex with men in some countries is very different to others. They could be facing situations of social alienation, marginalization, even discrimination, and criminalization linked to sex between men. We're very conscious of this, so we are looking at obviously contextualized messaging and approaches to make sure that we're reaching all people who need to be reached. Clearly, with 16,000 reported cases now, there are many more people who are also infected. So we need to consider this group as a group that requires specific advice, specific messaging and actions. You know, monkeypox can be very distressing. You know, if people need to take time off work, that can be really difficult. Potentially, they'll be worried about potentially losing their jobs if they have to take such a lot of time off work. And also, they may not want others to know why they are, you know, taking a step back from social life. So if someone discloses to you that they have monkeypox, really react without being judgmental. Don't make any assumptions of how they might have become infected. It doesn't help anybody. And respect their wishes as to whether they want other people to know about their illness or not. Practical advice around self-isolation is always a good idea. And also the mental health aspects of this need to be really thought through and addressed as part of the response. We've got a fantastic opportunity to really look at this globally. Vaccine inequity, we know, was a huge issue around COVID and continues to be. It's the same issue now around access to vaccines that are proven to be effective in monkeypox. And so I think already we're seeing, you know, even within countries that have access, there are, you know, elites, if you will, among the communities of men who have sex with men who are comfortable in queuing up publicly to get vaccines. They have the money to travel to different cities in order to get vaccines. They will make a huge effort to take time off work in order to get their vaccines. Not everybody in Europe and North America has that privilege. Many people will prefer not to be identified as gay, bisexual, or having sex with men, or they just simply might not be able to take the time off work to go and get a vaccine. So we need to be thinking about vaccine availability and inequities within higher income countries where we're seeing this this outbreak kicking off, but also it's a real opportunity for us to focus back on Western Central Africa. Why do we not have effective vaccines really being rolled out in the Western Central Africa context? So I think we need to work with all communities to think through how we can collectively do more to increase vaccine access and address inequities in countries, but also between countries as well. Finally, a couple of slides about an informal reference group that we've established at headquarters. What we've done is we've pulled together representatives from communities of men who have sex with men who've engaged with us on work on HIV and STIs, for example, in the past. And it's a really helpful group. So this group also, I should say, it includes MSM representatives from previously affected countries, so countries in Western Central Africa, as well as newly affected countries. So we're offering a platform for exchange between those community leaders, which is proving to be really helpful. So again, just exchanging best practices, barriers, and really trying to identify some solutions, and working with WHO at the global level is really helpful. We're seeing similar conversations being set up in countries where, in regions where there are additional challenges. We had a great meeting in the Eastern Mediterranean region, just I think it was last week, with community representatives who will take on some of the global level advice, but they will adapt it to the sensitivities of working in a region where there is a high level of criminalization in some of the countries in that region. So again, this community interface is really critical to be really effective in our responses, but also be sensitive to not unintentionally creating harm among the groups who are most affected. So let me just share in my final slide some of the key feedback from the reference group that have shared with us, and they shared this just prior to the emergency committee last week. First of all, I think there's a united feeling that the response requires greater urgency and certainly organised resources. There's an appreciation that spaces are being opened up so that communities can really be part of the decision making at WHO, but also elsewhere. We've recognized that this community, in some ways, we're fortunate to have this community. It's relatively well organized. The connections are there, so it's quite easy to reach this group. They're largely health literate because they've had to deal with HIV as an issue for many decades, and many of them are proactive around sexual health. So a proportion of this group are accessing ARV medication as pre-exposure prophylaxis, or indeed, obviously, some of them are also HIV positive. So they have regular interactions with health services, which really enables us to make good use of that interaction in looking for symptoms and cases and really moving to help contain the outbreak. Communities are playing an important role. We need to make sure that their efforts are appropriately funded. Many of them are funded to do other work and increasingly now are working full-time on monkeypox. We need to work with them on stigma and discrimination, but also, really look beyond stigma and discrimination to focus in on access issues. So access to testing, to vaccines and to antivirals, and also support to train health workers. We've hearing a lot of anecdotal evidence of missed opportunities for identification of monkeypox infection, particularly in the early months of the outbreak. And we need to do much more to really encourage that interaction between health workers and communities to be an efficient one and a respectful and dignified one as well. Again, there are some practical issues around, what might we do to support people self-isolating? Is there anything that we can do as WHO to reach employers so that they understand that they need to respect the confidentiality of individuals, and also note that even though the isolation is relatively long, 3 weeks compared to what we were used to with COVID, it should resolve within that time period, and they'll be fit to work again soon after that. So again, there are specific communities as well within MSM, for example, sex workers who've been really helpful to us thinking through the specific implications for that group. But I think stigma and discrimination approaches really need to be local. They need to be informed by the context. Best way to do this is really focusing on online misinformation and other misinformation that might be communicated. Some of it's done unintentionally, and we need to do really do more to support public health officials and health workers to have, as I said, dignified interactions with communities that are affected. So let me stop there. Supriya, I hope that those slides were helpful, and I'll stay online. Thanks.
Thank you so much, Andy, and very useful insights there. Certainly certain messages like monkeypox is nothing to be ashamed of, what we need to do to, what we can do, what different communities can do, and finally the feedback from the vulnerable groups themselves. Very, very useful indeed. Well, this is one webinar. We usually stick to time, but I think the topic's been so important that we've run well over time, and there've been lots of questions. Almost 70, more than 70 questions, and I'm really, I think we could take one question. But there's so many on so many interesting issues. I'm not even sure which one to choose. There have been questions on stigma, and there's been question on transmission to children. Perhaps Boris and colleagues, you could answer this one. There's a question that says, why is it that it's showing up? There are more people in the MSM group that seem to be affected, and also how is it that children are getting infected as well? Over to you. Is it a matter of testing access, or is it, do we know why this is the case?
I mean, if I could speculate that there have been multiple animal to human introductions at some point, followed by one or more of these human introductions becoming efficient human to human in likely the African setting, and then exported to Europe in potentially as few as one person, who then went on to enter into a very efficient sexual network that allowed it to propagate human to human. It is there are some genetic evidence that it may be better adapted to human transmission than in the past. When you look at but as I mentioned, it's about close skin contact. The virus doesn't care what your sexual orientation is. If you are a gay man who's in a stable relationship with another person, an exclusive relationship with another person, you have no risk. If you're having close skin to skin contact with somebody by any mechanism, you are at risk. And so, for example, I can think of a child who was infected because the parents were infected, and they transmitted to the child, because any parent will have close contact with their children, hugging them and so on. So but then the extent to which that has kind of propagated onward has been quite limited. So again, if you had, I think that if we're not seeing a lot of women, but in theory, a woman who has many sexual partners in a month, and if those partners have many sexual partners in a month, the risk is going to be high as well. It's I think some of it is what we call the founder effect, where the outbreak starts is still where a lot of the cases are, but as of now, we're not seeing a lot of spillover into other population groups. As I mentioned, it doesn't seem to be very efficient in contexts where you don't have many people having close skin to skin contact with many other people.
Thanks, Boris. Thanks for that. Since I'm looking at the chat and there are a number of questions on stigma. So although I said one question, I'll just quickly throw one to Andy on what should one do to prevent stigmatization? You've covered some of this in your presentation, I know, but
thanks. I think the number one thing is really focusing on the evidence. Don't make assumptions beyond that. So, for example, I think one of the things that I suggested was, if on a personal level somebody discloses to you that they have monkeypox, just don't jump to any assumptions of how they may have become infected. We've got a lot of learning from tackling and addressing stigma from HIV. And that's a critical one. It doesn't matter. They have the monkeypox infection. Focus on how can I help you now? How can I be supportive now? So I think, again, just trying to really recognize, as Boris was saying, that there are multiple modes of transmission. And frankly, even those that have got monkeypox through having, for example, multiple sex partners, the last thing they need is any kind of like blaming or shaming. They require our support, our solidarity. We're all learning. So again, communities are already adapting their behaviors. So I think let's focus on the evidence, focus on the data, and take our lead from communities who are really at the heart of this. They will offer us some good advice, and it will be contextual. I've seen in the chat, questions about what about Muslim countries and how can we reach them? My shorthand answer to this is, gay communities exist in every country, and often probably the best route is to have a look at what's happening around community involvement in HIV in those contexts, and they will advise you on how to manage some of this, because frankly, we can do a lot of this work without even talking about MSM or LGBT issues. We can talk about risk, we can talk about effectively getting services to people who feel they might be at risk. And it's those communities, particularly who've been involved in HIV work in every country context, that I think we should be listening to. Thanks, Supriya.
Thanks very much, Andy. And very quickly, we had two excellent presentations from our colleagues from WHO, Afro, Thierry and Jean-Paul. And Thierry has his hand up, so over to you.
Okay, thank you very much, Supriya. Just to pass the message, this is a viral disease. Monkeypox is caused by a virus, which can affect anyone, regardless of your religion, your gender, or whoever is monkeypox can affect. For that reason, I think that the story is not over yet. Sooner or later, even me, I may get it. For that reason, we need global force, global unity, and to address the topic for everyone, for the world. That's what I want to pass as a message. And we hope you all will contribute to it. There are speculation about the data, but let's focus on the purpose to stop the outbreak. Thank you.
Thank you very much. On that note, very relevant. It can affect anyone, and we must all work together globally. Thank you very much for your participation. Thanks to all the presenters for the excellent presentations. And really, as someone mentioned on the chat, we should have organized a longer session perhaps, because each of the presentations was so interesting and so important. Thanks to all the participants for their very active participation. We've tried our best to answer your questions. We will continue to do so, and we will share all the presentations. And the recording will be on YouTube as well as on our website. Please do keep in touch, keep your questions and queries coming, and your thoughts as well. And thank you very much for your participation, and hope to see you in the next WHO EPI-WIN webinar. Thank you all. Bye.